So the next debate is on intravitreal steroids versus anti-VEGF in macular edema. This is our final debate. I would like to invite Dr. Aruna Fernando. He's a consultant VR surgeon at KDU, and Dr. Sriharanathan is a VR surgeon at Kandy Hospital, to come up to the stage. And I would like to invite Dr. Dilini Vikramaratne and Dr. Prasad Hewavasam, senior registrars in ophthalmology, to speak out on this debate. First, Dr. Prasad is going to go. Yeah.
Okay. So good afternoon. I'll be presenting to you on anti-VEGF versus steroids in diabetic macular edema, and I am pro anti-VEGF. So VEGF is the principal and the main mediator in diabetic macular edema. It breaks down the inner blood retinal barrier, causes fluid leakage, leading to macular edema. So to treat macular edema, you need to target VEGF. So therefore, anti-VEGF therapy is the main and the principal mainstay of treatment. But in the community, there's an unreasonable belief that steroids works better, because usually what happens is we give 1 or 2 doses of bevacizumab and we expect immediate results. But like if bevacizumab do not produce good results, you got to have used ranibizumab, which is more powerful, more potent than bevacizumab, or perhaps aflibercept, which is even better. So if you use the correct anti-VEGF, correct dosage, and for adequate duration, you can often dry up the macula. So let's look at evidences for each of these anti-VEGF agents. So BOLT study shows bevacizumab is superior to laser treatment. And RESTORE study shows ranibizumab with or without laser is superior to laser alone. And then RISE and RIDE study shows ranibizumab had a superior visual acuity outcome over sham injections. And in VISTA and VIVID studies, aflibercept was compared with laser photocoagulation, and aflibercept showed superior visual outcomes over laser. And the Protocol T study compared the 3 anti-VEGFs, and when your visual acuity, when you have mild visual impairment, both perform similarly well. But if your vision is 20/50 or worse, aflibercept was superior. Now this is faricimab, is the first and only anti-VEGF which actually target 2 distinct biological pathways, both angiopoietin and VEGF-A. So the Boliviad trial showed that faricimab is superior to ranibizumab at 24 weeks. And the Yosemite and Rhine trials showed that the treatment duration of faricimab can be extended up to 16 weeks, and still the visual acuity gains could be maintained through 2 years. Now talking about steroids, the Protocol B study shows that laser is superior to triamcinolone. And in this study, 50% of eyes underwent cataract surgery due to triamcinolone, and 30% of eyes developed high IOP over 10 millimeter mercury. And Protocol I study compared ranibizumab with prompto-deferred laser with triamcinolone, and ranibizumab showed significant, substantial visual acuity outcome at primary endpoint at 1 year. And more importantly, the visual acuity gains were maintained through 5 years in ranibizumab group, in contrast to triamcinolone. Now the Protocol U study showed addition of dexamethasone to ranibizumab was of no benefit. Now if you look at the graph above, you can see it, but this is not due to cataract formation, because in this study, the pseudophakic eyes, the results were consistent even with pseudophakic eyes. And so you can see the steroids only reduce the retinal thickness, but no visual acuity gain. Now the highest evidence comes from meta-analysis. So this is a Cochrane reviewed analysis which analyzed 14 clinical trials from 2005 to 2021, and it showed that intravitreal steroids were not superior to anti-VEGF. And more importantly, it caused a lot of intraocular pressure-related events. So last but not least, if you are thinking of giving steroids, think twice, because anti-VEGFs usually works. Thank you.
Thank you, Prasad. So I would like to invite Dr. Dilini now.
Good afternoon, everyone. Thank you so much for the opportunity. I'm talking towards steroids in diabetic macular edema. Diabetic macular edema, I'm not going into details because you all know it's hyperglycemia-induced breakdown of blood-retina barrier, and it causes retinal thickness increase, and when the fovea is involved, the severe loss of vision can occur and needs treatment. And you all know the classification, clinically significant macular edema and OCT-based classification, which I'm not going into details. So coming to the topic, commonly used steroids in the diabetic macular edema is dexamethasone implant, which is a potent anti-inflammatory agent, and its potency is twice that of fluocinolone and 5-fold more than that of triamcinolone acetonide. And the second option is triamcinolone acetonide. Dr. Prasad mentioned the cataract formation and glaucoma. The triamcinolone causes increased risk of glaucoma, yes, but that's why two sustained release drugs such as dexamethasone and fluocinolone were developed. The third drug is fluocinolone acetonide. The routes we use commonly is intravitreal and also periocular and suprachoroidal. You were talking about you have compared anti-VEGF with laser most commonly, but I'm going into details with steroids compared to anti-VEGF. The role of steroids, this is the study which I've published in 2019, a review article. Corticosteroids provide powerful anti-inflammatory and anti-edematous effects. It also decreases the VEGF synthesis, both, not like in anti-VEGF. It causes a reduction in anti-VEGF plus anti-inflammatory, and it has also anti-edematous effects as well. And consequently, it increases blood-retinal barrier. The improvement occurs because it also blocks the arachidonic acid pathway via phospholipase A2 inhibition, and hence downregulate the synthesis of some other cytokines which are involved in diabetic macular edema. So the use of intravitreal steroids in diabetic macular edema, there are a lot of indications. One is a non-responding or poorly responding cases for intravitreal anti-VEGF, even after you switch off to the other types. Alternative to anti-VEGF in pseudophakic patients as first-line therapy, according to DRCR protocol I. And patients who have a recent history of a cardiovascular event or pregnancy, especially, and inability or not willing to adhere to monthly treatments, because in anti-VEGF, at least you have to use monthly. Diabetic macular edema in eyes undergoing cataract surgery at the same time you can use, and vitrectomized eyes to avoid repeated injection burden, hence the risk of endophthalmitis, and the patients have low cost and limited clinic and OT visits. In conclusion, according to this trial, they say intravitreal corticosteroids provide substantial anatomical and functional growth, not only the central retinal thickness, but functional improvement as well, which are refractory to diabetic macular edema anti-VEGF treatments and both naive cases. MEAD study, it's a 3-year randomized sham-controlled trial of dexamethasone intravitreal implant. They evaluated safety and efficacy of dexamethasone, two types, 0.7 and 0.35 milligrams. And the conclusion was there was improvement in base-corrected visual acuity and central retinal thickness compared to sham. These are the results, 15 or more letter gain. Finally, at the end point, dexamethasone had more visual gain than sham control. And DRCR protocol I, they evaluated 3 different treatment schemes. The outcome was pseudophakic patients treated with triamcinolone had similar efficacy to ranibizumab treated group, not inferior. And this study, a recent study published in 2023, they have studied fluocinolone acetonide intravitreal implant, reduces treatment burden diabetic macular edema. So the overall at 36 months, the mean number of yearly treatment decreased at fluocinolone treated group. And after fluocinolone, the percentage of eyes requiring supplemental therapy also decreased. And the mean best corrected visual acuity also had been increased. So these are the pre and post treatment, repeated treatments needed, laser, anti-VEGF and corticosteroids. The post fluocinolone treated group had less number of supplementary therapy. And this is again...
I need to stop you because we are running out of time. So we'll move to the... Thank you very much. And Dr. Sri, are you a steroid fan or an anti-VEGF?
In fact, I'm a fan of both because the first speakers highlighted that the faricimab is superior to any of the available this intravitreal VEGF agents because this orchestra of events in macular edema run by lot of players are there, not only the VEGF. There are so many players, but VEGF covers only certain, they mentioned that is a key player. But when faricimab, when you have mentioned that, it is a bispecific molecule which covers beyond anti-VEGF, VEGF, that is angiopoietin A. So there are so many players are involving. So I thought, with my common sense, if it is not contraindicated, I will give both together because I want to cover as much as possible the players are involved in macular edema.
Dr. Aruna?
Yes, I think it was a very nicely presented debate from both parties. The management is obviously not that complicated now. It's quite straightforward. I think most of us would be starting with anti-VEGFs, loading with the 3 doses, and then I think we, as Dr. Sri said, we will be addressing the other players and attending to the anti-inflammatory property as well. But in our setup, in our country, you have to think about the cost factor. And although the studies and research do mention this, all of you all, including ourselves, we know that the management that we do is not exactly what is mentioned here because the cost factor plays a huge role. So unless you think about the patient's affordability and if you do not think about the patient's economics and their social background, ultimately you will lose the patient and the patient will actually stay at home forgetting about everything and not getting anything at all. So I am a fan of anti-VEGF, yes, to start with, but afterwards when I understand that the patient cannot have repeated injections, sometimes I do tend to go for the cheapest option, which is triamcinolone. So it's not the best possible option, even among the steroids, but sometimes we have to think about keeping the patient in our clinics and making sure that we can do the best for the patient under the circumstances. So it's always good to know the right way of doing it, yes, but always ultimately you shouldn't forget that you are treating the patient and you don't want to lose the patient. So a lot of money is involved with this. So I am again, just like Dr. Sri, a fan of both. So have to selectively give it, not only considering the research, but the patient's economics as well.
So what about dexamethasone implants? Have you used it as first-line therapy or?
No, I am in that line. I would always start off with anti-VEGF 3 doses. I do not give dexamethasone as the first line now.
Yeah, dexamethasone is pretty expensive one, but I have tried this suprachoroidal triamcinolone, very cheaper method, which its action lasts around 3 to 4 months in my anecdotal evidence. So if you consider your patient, cost is a very important factor. The suprachoroidal triamcinolone would be the best option. Combining with Avastin or anti-VEGF in the same table, you can give both, but you need only 2 or 3 injections per year. I'm trying to get an evidence from my own experience. Probably I might release in future.
Interesting. Thank you very much, Dr. Sri and Dr. Aruna. So we have come to the end of the debate, and thank you very much for listening.